Good afternoon, everyone, and welcome to QITalktime. Today we have Dr. Marie Ward with us, and she's going to do an intro to human factors and ergonomics for healthcare. We're delighted to have Marie with us. She's currently based in the Children's Hospital as a project manager and has a strong background in human factors, both from Trinity and the aeronautical airspace area. So we're delighted to have us with us today. So here are the phone numbers, so 015260058, and the event number is 844-122-707#. Keep the questions coming, and there is a chat box there at the bottom right-hand corner of the screen. So without further ado, I'd be delighted to introduce Marie to us today, who's going to take us through the content. Thanks a million.
Okay, thank you, Roisin, very much. And just want to say thanks to Caroline as well and the QITalktime team here for inviting me to come along today. So hopefully at the end of this session, I will have given you an introduction to the science of human factors and ergonomics. And the terms are synonymous. It's just on different sides of the ocean we tend to use different terms, but they mean the same thing. And explain why human factors is important in safety critical industries like healthcare. And then give some ideas maybe on how you could go about introducing human factors, ergonomics principles and practices into your work area. So I suppose just before I start, I mean, this is going to be a real fly through different areas in relation to human factors. In aviation, when we do an introduction to human factors course, it usually lasts 3 days. So I'm giving you a very synopsized version here today. But please, if you do have any questions, please put them in the chat box and we can stop through the way to answer, or we can answer at the end. So just to say, human factors or ergonomics is the scientific discipline concerned with understanding the interactions among humans and other elements of a system. And it's the profession that applies theory, principles, data and methods to design in order to optimize human well-being and overall system performance. And the webinar today will be structured around these key terms. So just a bit of background, when we say the profession, traditionally human factors professionals have been from either psychology or engineering. And that's changing now with more access to masters and different research programs for healthcare staff and different staff in general. And I'll talk about that at the end. So I suppose systems thinking, I love this picture of the elephant. It's actually from a poem by Rumi, where he had the blind men feeling the elephant, and they all thought it was a different thing. So depending on what part of the elephant they were touching, and I suppose it just characterizes, what isn't systems thinking, I suppose, and then explains that just to say that human factors and ergonomics, we always look at the whole, and we recognize that the whole is greater than the sum of the parts. So what are the parts of the system? Well, if we look at this diagram, maybe just moving from left to right, it's us as people, as individuals who work within the system, as patients in healthcare and as staff. It's teams that we work in, it's the organizational structures. On the green is the workplace environment, the tasks, the tools, the technologies, the machines, the equipment that we use. And I suppose linking those then is the, there seems to be a problem with the audio.
All right. Okay, everybody, we're just going to put in the dial-in number into the chat box again for you there, just to make sure that you can hear okay. So sometimes the audio can cut out over the computer, so we've typed in the phone number and code in there. So Denise, hopefully you can get that. Sorry, Marie, for interrupting you there. Okay. So the chat box, click on the little chat bubble and the information will come up there, and keep any comments or questions coming in there as we go along. Sorry, Marie.
You're okay. So just to say that overall this is the whole system, and we talk in human factors about socio-technical systems. So we have all the social relations and all the technical system, and the technical means, I suppose, the professional, the tools, the technologies, the tasks, the work process. It's not just, it's not just technology. It's all around the technology. And then what links that, what helps us to link and understand what we're doing, is how we share data, how we share information and knowledge. And then what is the purpose? So what's the purpose of the activity? What's the purpose of the organization or the system? What is the vision or the mission and the goals? And we'll talk about different parts of this. So just if we look at the system, we look at who do we work with? Who do we work with and in what context? With what tools and technology? How do we use tools and technology? Why do we use them? For what purpose? And then how do we make sense? What's happening and what can I do? So how do we make sense of our world and our environment? So I suppose just to say that the organizational culture, this is from Professor Nick MacDonald in Trinity College, who set up the Human Factors Research Group there about 25 years ago now. And I think this diagram really captures what we're talking about when we talk about a system, that when we try and make sense of our world, so you'll have heard, terms like cognitive bias or hindsight bias or different things like that, and we talk about those. When we try and make sense of our world, we make sense of it in the culture that we're in. So it's the organizational culture that we're embedded in. We act out of that understanding, and then our actions justify our understanding. Our actions, our collective actions, then produce the system. The system will always reflect the culture and reflect who's in it, so that's us within it. So I suppose it's constantly changing, and that's where this concept of emergence comes from, that when we're in a complex, and healthcare is often has been described as the most complex socio-technical system in the world. So when we're in that really complex system, we're constantly reflecting and creating and defining and justifying all the different parts of that system. And that's us as people trying to make sense of it as we go. So one of the definitions of culture is kind of the way things happen around here. Edgar Schein would say it's the values and the beliefs and how that's reflected in the system. So we'll talk about these different things and maybe how human factors can help us understand these. But I suppose the main point is that human factors always, the starting point is always looking at the system, and we're always trying to understand the complexity of the system. So that's where we always start, is trying to understand and model what actually happens. And you hear about different change initiatives, and people will have different starting points, and they'll say, oh, we start with, understanding the problem. And that's fine, but we have to understand the problem within the context of the system. So in human factors, we will always start with understanding the system. And that's why we try and spend time mapping out these different elements. So I suppose just some background terms then, because we often take for granted things like we are working within a functional system where there are clear objectives and their activity is planned and structured to match those objectives, and we have clear outcomes. And that's not always the case. I suppose we can't always assume functionality. And we coined this term in aviation called WIPEDO, and it's this idea that there are well-intentioned people in dysfunctional organizations. And that's a reflection that people do want to come to work and work well and work to their best of intentions, but oftentimes the system can frustrate people. I just was reading Deming this morning, and he says, the bad system will always overcome or overtake a good person. So I suppose that's in healthcare we have to look at what kind of systems and structures we have. And in aviation, we had carried out a study in 2000, and we found that the best people, the best technicians, the best engineers often made the worst mistakes, and they were the ones that were trying to grapple with the system and trying to understand how to overcome that dysfunctionality within the system. So I suppose that just links to this idea of work as imagined. So we sometimes take as our starting point again that idea that we have these functional systems, that work is carried out according to our procedures, policies, protocols and guidelines, our PPPGs or our SOPs, our standard operating procedures, that's how work is carried out. But I suppose we all know, and it's becoming clearer in all the research, that that's not really how work actually happens, that we have the normal, the informal system. And I like this diagram here on healthcare, that there are different variants of that too, that we have work as imagined, work as abstracted when we think about what we're meant to be doing, work as when we engage in simulation, work as observed, work as documented, work as claimed when we have to there's two rather cross-looking people there when we have to, justify our actions, work as claimed, and then in the centre we have some mix of all that, which is work as done. And I suppose, what we need to be careful about is which system we judge people against when we do make mistakes, and I'll talk a bit about safety culture in relation to that. We tend to judge against the formal system when people make mistakes. So without the full understanding of the entirety of the system. And again, another study in aviation, when, this is around 1999, we did a pan-European study of whether aircraft maintenance engineers followed the standard operating procedures, and found that only 33% of them followed them all the time. And that was a shock kind of moment in aviation, because it was, people thought aviation was very proceduralized, very regulated, and people always did, all their activity according to the procedure. So similarly, there are studies in healthcare, like the study Gerst's 2010, and they look at why don't clinicians follow clinical guidelines, and they look at different aspects from the clinician, the guideline itself, the system, and then how it's implemented. So I suppose we have to understand the whole system in order to understand why, how it works, and that's always the starting point.
Sorry, Maria, just picking up on something that you said there, I think might resonate with our listeners, but you were saying about in health, how often it can be judged against the formal system, and I wonder, are people online familiar with that? And I suppose we are moving away from that and trying to do things like after-action reviews, and there are other systems in place that would hopefully assist, taking a broader view at something. Have you any? It might come up a little bit further in the talk in terms of how to do that.
And the new incident management framework is very focused on systems analysis, and that is so important, to carry out a thorough systems analysis and try and understand, not just one root cause analysis, but key causal factors, and understanding the system and understanding all the issues behind. And then things like after-action review are so important for, immediate learning. So, the 4 questions, like what, I'll probably say them in the wrong order now, what
did you intend to happen?
What did you intend to happen? What actually happened? Why? What was the difference?
Yes.
And what is the learning? So it's things like that where we try and get to grapple with those underlying assumptions that we make about work and about how the system should work. Okay.
But it fundamentally comes back to having time to be able to do that though as well, and time to reflect on something you were talking about earlier, that constantly changing environment that we're in, and having that time for reflection. And as a team coming together to think about what is happening and what can we change. And
and just talking to so many people in healthcare, everybody seems to be so busy, just so busy, and there's no time. We kind of engineer out those time for reflection, and it's not seen, it's not valued as important, that time for reflective practice.
Checking there. So we have 25 people online, so any questions, keep them coming, thanks.
Okay, so we'll just move on to, I suppose the starting point then in human factors. Again, there are different models for how you do this, but it's really trying to understand your current system. People might have heard of the SEEPS model, which looks at, the different factors I've talked about, the technology, the tools, the organization, and then the processes of work and the outcomes. The SCOPE model is one that's emerged from all the research in the research group, the Human Factors Research Group in Trinity, looking at those elements, the system, the culture, sense-making, action, and then looking at those in relation to the goals. So, are we all clear about the goals? Are we all clear about, our aims and objectives? Are they linked to those of the wider organization? Do we understand our work processes? Do we know our team? I'm going to talk a bit about healthcare teams. Do we have the information and the knowledge we need to perform our work to the best of our ability? Do we have the right tools and technology? So it's just looking at, and that's been applied in different studies. You can have a look at those in terms of understanding the organizational system. So just to say, that was on kind of the first word of that definition, which was system. Just a bit on methods. Human factor methods are very mixed, but I suppose they always, again, as their starting point, is that trying to really get under the bonnet, as they say, or trying to understand the system, and always take a human-centered approach. So lots of participatory action research or ethnography, observations of work, has it actually happened, using co-design and co-production to try and look at engaged staff and patients in redesigning systems, looking like things like the Institute for Healthcare Improvement, looking at not just outcome measures but process and balancing measures to try and see are there any knock-on effects down the line. So again, there's very mixed methods, but always taking, I suppose, that look at people and systems and how they interact. Just in terms of design, the ISO 6385 looks at human factor ergonomics principle in design, and I just thought maybe we would just think about this in terms of, say, electronic health records, So, I hear people moan and groan when we talk about electronic health records, and I think that they, at times they can be, they can be brought on board without understanding the processes underlying them. Like, technology should always support the process. It should always support how we work and support the system. So if we are doing that, you need massive human factors investment in the beginning. So all the investment should be in the beginning in terms of mapping out the current processes. What information do people need? When do they need it? Where do they need it? And then you design your technology around that. What information do people need to share, and what's the best way to share that? So human factors is used as a preventative tool, so you're trying to constantly design better systems, and design means at the beginning, when you involve the workers in that, and in designing the work systems, and you'd read such, I read a very, on Twitter, a very sad article about a doctor commenting on Epic, and just their interaction with that electronic health records. So it's just, how can we design tools and technology to support people, and that's where you start the process, start human factors efforts. So I suppose it's about optimizing performance. So this is the next words in the definition. And I suppose it's impossible, when you look at that, go back to that model of an organizational system, it's impossible to eliminate all mistakes in any complex socio-technical system. So what we're trying to do through human factors and ergonomics is to reduce the potential for making mistakes in the first place. And then if we do make them, to try and capture them before they become errors. So the human factors definition of safety isn't about zero error or reducing error, but it's about trying to understand the human performance and human well-being. It's trying to optimize that. And in healthcare, I've heard these stats like the 10, 30, 50% figure, and that's that we have 10% error rate. So we have 10% mistakes in healthcare, and that's probably a conservative estimate if you look across the literature. So in terms of patient harm, we harm 10% of our patients. 30% is waste, so that's how much waste is estimated. This comes from the works of people like Jeffrey Braithwaite in Australia. And 50% is a 50% reliability figure. So when we're doing evidence-based best practice, we do it 50% of the time. So I suppose there's lots, it's to acknowledge those difficulties in healthcare and look at that, but also to say that we can improve. There will always be mistakes, but we can improve on things like reliability and waste, and try and through better design, reduce error, and reduce the harm that error can cause.
And just actually on that last slide, Marie, about reducing the potential for making errors. Obviously, human factors is probably used with a lot of other techniques like lean and quality improvement methodologies. I suppose, encompasses. You could have an approach that has multiple things that are taken into consideration.
Yeah.
And maybe later on in the talk, we're going to talk about some of the things that we would tools or how people might use human factors.
Absolutely. Yeah. So I'm just coming to that now, and a lot of the human factor tools you will recognize. So these are tools that have come from aviation and other industries, but you will recognize them within healthcare. So optimizing performance is the last part, I suppose, of the definition of human factors and ergonomics. So I'm going to chat through different tools and techniques that can be used within healthcare to try and optimize performance in these different areas. And I'll just go through those now. So just in terms of culture, I suppose safety culture, we hear about the term and we talk about it, but just, I suppose it was first used in following Chernobyl, and it's, how we as individuals or groups, it's our values, attitudes, perceptions, competencies, and patterns of behaviour that determine the commitment to and the style and proficiency of an organisation's health and safety management, was the UK Health and Safety Committee definition that followed on from Chernobyl. But I suppose basically it's how committed are we to safety in our words, in our deeds, in our values, in our vision and mission for the organisation. How committed are we to safety culture? And just there are different components, like James Reason, who some of you may know from the Swiss cheese model of accident causation. James Reason was the first to kind of coin this term, just culture, in aviation. So I suppose it emerged from trying to move to a no-blame culture because we wanted to encourage as much reporting of mistakes and near misses and accidents and incidents as possible in aviation to continuously learn and improve. So we introduced a kind of no-blame culture in aviation, and he was saying it doesn't really work because you cannot provide a blanket amnesty on all unsafe activity. So if people deliberately harm or violate aircraft or safe procedures. So what he came up with was this term, just culture, and that comes from the term justice. So it's where people feel trusted enough, feel supported enough, feel encouraged enough to provide safety-related information and to talk about mistakes and errors and incidents, but where they're also clear about what's acceptable and unacceptable behaviour. So just in terms of healthcare, I suppose, what's needed for that? What's needed to try and shift safety culture? And most of the research would say that without a safety culture, without a really good safety culture, we can't progress on improving patient safety. And if you look back to the 1999 To Err Is Human, we haven't really improved patient safety as much as we possibly could have since then. So psychological safety is really important for that, and that's this feeling that you are held, that you are minded, that you're protected by senior management. And it's the Lucien Leap Institute. So Lucien Leap was the author of that first report, To Err Is Human, and has since written this report, Through the Eyes of the Workforce, in 2013, where they made the direct link between staff feeling that safety of being able to speak up, for safety, and patient harm. So it's the first time I think a direct connection was made, that staff need to be able to speak up.
And just on that, there, Marie, sorry to interrupt, there is the webinar on the 10th of December, the co-lead, but their tools, actually some of that will relate to this in terms of the safety cultures, and also, through the HSC and through some of the work in the quality improvement team, for example, open disclosure, the person-centeredness program, values in action. There are a lot of different things that are out there trying to address this.
Yes. Yeah.
But different organisations will obviously be at a different stage. Yeah.
And from a systems perspective, there's so much that you need to change to introduce something like this. If you think about, and the incident management framework, the new framework does have the just culture algorithm within it, in terms of treating people if they've been involved in an incident or an accident. It also means, understanding systems and understanding emergence and understanding that, there are simple tools, like one developed from aviation is just a substitution test. So if that was me with the same skills, same training, same understanding, same colleagues, same everything, would I have done anything different? Yeah. Would I have done the same thing? So there are simple tools that can help. And so I'll just go on then to the other box with sense making. I just invite you all to read what's in the triangle in the top right-hand corner, just to read it. So how many of you read I Love Paris in the springtime? You don't have to. You don't have to answer.
We can use the chat box for this. Yeah.
But if you look at it again, what it actually says is I love Paris in the springtime. And there are great examples and videos like this of looking at, the amazing thing about us as humans is we're able to process so much information, but we use schematics to do that. And we rely on, I know what that says, that phrase, I know that well. We use schematics to do that, but what happens is then we can make mistakes, and we can work off our assumptions, and we can introduce biases then into our thinking. There's some great videos that illustrate this, like people might have heard of the monkey business illusion, which is the one on the right there. The other one is extraordinary. It's a deal or no deal, where one of the models is actually the contestant's sister, and she just can't see that it's her sister, you know, because she's just expecting to see a model. And so it's funny. There are different things that show us that when we expect to see things. So there are ways of helping us then in terms of dealing with those. So there are, you know, checklists, you know, understanding, I suppose, where we are. Situational awareness is so important. Understanding my current environment, understanding what's happening, what's likely to happen in the future. And it was Margaret Ainsley that came up with this concept in the 1980s, and it has helped, like, in terms of creating these different tools like ISBAR, which again came from aviation. I don't know if it was the aviation or the Navy, I'm not sure which, but anyway, just contextualizing, you know, who am I, what is the situation, what's the background, what's my assessment, what's my recommendation, and then ISBAR 3 uses the readback and the risks as well. This surgical safety checklist, the World Health Organization safety checklist, again, it just helps us to look at where we are and to, you know, we use schemata because we have to take in so much information. Whereas checklists just help us to go, okay, do I need, you know, what have I to do here, and helps us to remember different things we need to do, and also helps us to just contextualize where we are in that moment. So in aviation, say there's something that if you get interrupted during a safety critical task, you have to go back 3 steps. And we did some work in the emergency department, and where one nurse said she was interrupted 156 times in an hour. So we were thinking if she had to go back 3 steps every time, you know. So sometimes the environment isn't always conducive to that. But if you think that if it's really safety critical, how can you put yourself back in? If you're interrupted and called away, how can you go back and put yourself back in where you need to be? So that's where these tools and techniques help.
And one thing on that, Marie, is I suppose, you know, in hospitals and CHOs, people are very busy, and sometimes there can be a feeling of checklist overload, or there's a little bit of fatigue around checklists, and there's a piece, it creates more work in some sense for people. So there is a balance there to be struck in terms of maybe if you are making a change, that you implement a checklist to support that, but once it's sustained and you've seen sustainability within it, maybe you relook at the need for the checklist. I don't know if you have any experience of that.
I suppose checklists are only meant to support the process. So if they're adding additional work, then they're not really designed very well, or they're not, you know, they're not doing their job. So, you know, the surgical safety checklist came from Boeing. Now that within Boeing, like within, I mean, I don't want to speak too much about Boeing given all that's going on at the moment, but within aviation, checklists are so embedded into daily practice. They're not an additional, they're not an add-on. They're designed in from the beginning. So I suppose there's a danger as well in taking tools and things from other industries where we're not using. That's why I started back with the systems, you know, where we're not designing them in to support the process. So people will get frustrated and fed up and go, oh, here's another thing we have to do, and they won't understand why we're doing it, or what's the point, or won't understand that it's about cognitive overload or situational awareness. So just in terms of situational or safety, huddles are really important as well. So safety, you know, we had in Children's Health Ireland, we had Professor Uma Kotagal over from the Cincinnati Children's, where they've implemented in Cincinnati high reliability organizations, and huddles are such an integral part of that. You know, that you're bringing people together, you're discussing, you know, what went wrong over the last while, you know, what might happen in the next while. Who might we harm, and they call those people watchers, like those patients that we need to watch them, we need to be careful, we need to be mindful. And again, it's trying to introduce that sense of situational awareness around the team. So just in terms of then the teamwork in communication and simulation, a lot of programs have come from other industries, and they're all based around crew resource management, which is from aviation. But it's trying to look at, you know, how do we implement these within a human factors framework? So we're not just, you know, as you say, it's not just another thing we have to do, or, you know, there is a misunderstanding that human factors is about communication, but it is about communication, but within the system, and understanding that. And I suppose this slide I think is really good from Mike West in King's Fund. He did a lot of work on team working, and the co-lead work that you mentioned, is building on this as well. That in healthcare we have these very, very siloed teams. So, if you ask a doctor who's on their team, they'll say it's the consultant or the reg or the SHO. If you ask a nurse, it's the nursing team, the HSCPs, it's the HSCP team. So what they've found is if we don't have, if we have teams where we don't have, shared objectives, where we don't know who's on the team, we don't know where we fit in the overall structure, and we don't engage in reflection, like we talked about earlier, the importance of reflection, then he calls them pseudo teams. And the important thing for our, if people can see it under the chat box there, but it's just that if you are in a pseudo team, if you're not in a real team, you may as well be working on your own than being in a pseudo team. So teams in healthcare are very, very complex. And if you include everybody in the team on a ward, say, you could have up to 70 people. So how do you create a team out of that?
And I think a key part of that, I'm just referencing back the co-lead work in terms of role clarity, and there's so much role overlap, I think, as well in MDTs, for example, with health and social care professionals, and so I think that comes into play, doesn't it, in terms of how the team works, and clarity around that is so important.
Absolutely, And in UCD, when working on the co-lead project, we were developing tools to try and get things like this, like the clarity around tasks, and Aoife De Bruin is going to speak about that, as you said, in 2 weeks. So then just frozen for a second.
Yeah, I think we actually have some questions there as well. Oh, just someone can't hear. We'll just put the phone number and chat into the chat box there. So phone number and code will come in to the chat box. Okay.
Okay, so just then in terms of the organisation, I suppose people might have heard these terms Safety 1 and Safety 2 in terms of the system and how we approach safety. And this idea of Safety 1 and Safety 2 emerged from aviation again, and Eurocontrol wrote a white paper on this. So they were saying within aviation we have looked, we have really analysed, and we spent a lot of time, and people might watch all those documentaries on accidents and disasters and what goes wrong, and really trying to understand what goes wrong. And they were saying if we are to move safety in aviation to completely into an ultra safe system, then we need also to look at the kind of normal day-to-day performance where things don't go wrong, and then look at exceptional performance as well. Now, I have to say, I probably don't know enough yet about healthcare to know if this is as applicable in healthcare, because, when you talk about 50% reliability, then, can we assume a normal distribution in healthcare? And I don't know that. That's why I suppose in healthcare we still need to spend time really understanding. I don't know if we do that kind of key causal analysis or systems analysis as well in healthcare as we probably do or as we do in aviation, or if we really do understand the system, so understanding how the system works. So I don't know how I feel at the moment about this in healthcare. I mean, I'd be interested in what other people have to say on this. But this, I think, probably more reflects the situation in healthcare, and it comes from René Amalberti, and originally from Rasmussen. Rasmussen's work on procedural drift. So this is Charles Vincent and René Amalberti, and they're looking at, it's that we try and work in these safe systems, that we try and work within the kind of the rules and the protocols and within that, but we don't always, because we don't have the resources, we don't have the time, we don't have, there's lots of things can happen, and we end up drifting into these spaces that are unsafe, and while there are agreed kind of forbidden spaces for all staff, there is this kind of grey area in between. And that just links back with the idea of just culture, that the first thing in defining or in understanding and trying to introduce just culture is actually defining really what are these forbidden spaces. So where are the clear lines between what's acceptable and unacceptable? If we're all so stressed now, we're all so busy, we're all performing with probably less, staff than we need, how do we navigate those spaces? So just I think this is the last slide of the talk, is just around governance and accountability, and I suppose data information and knowledge flow. This is one big passion of mine, I suppose, is just in terms of transparency of data and information and knowledge. And I worked on partnership, social partnership projects way back for, just trying to get unions, management and staff working together. And I just saw firsthand the power of information, the power of having data and access to data and access to information, and being able to translate that into knowledge and into changes and improvement in practice. And what's required for that is, transparency. And so I really advocate using quality boards and quality and safety boards and putting, as much information as we can up there, and, across, in different hospitals, you can see that they will put up infection rates and different things, and I think that's really good. And the more we can involve patients and staff in that, the better. And I suppose just around governance structures, that for any, human factors is a whole science of safety. For any change or improvement or quality and safety initiative to happen, there has to be clear governance, there has to be clear accountability, there has to be all those implementation supports and structures in place we need for any of these things. Lucy and Leap has a great quote that lack of accountability is healthcare's dirty little secret. That we struggle with that in healthcare. So it's trying to look at that and look at transparency and information flow. So I suppose just to finish there, that has really been a whistle-stop tour of high-level concepts around human factors. But there are resources out there. There's some great websites. The Clinical Human Factors Group in the UK was set up by a pilot whose wife, you might have heard of him, Martin Bromley and Elaine Bromley. She died during routine surgery. You have the Irish Ergonomics Society. You have Safety Differently, which is from Stephen Sheriff, who's works in Eurocontrol. The Safety and Health Systems Twitter handle is there as well. There are great journals on human factors ergonomics, like Safety Science or Ergonomics, and BMJ Quality and Safety are as well are publishing more around human factors, which is great to see. And then just in terms of further study, the RCSI have their Masters in Human Factors and Patient Safety, and there's an online diploma in Trinity as well on systems, changing risk and change in complex systems.
Thank you so much, Marie. Everybody is very quiet on the chat box. No questions or comments coming in there. So if you do have any, please do type them in. We do have 5 minutes to deal with any questions if anyone has them. Thanks so much for a whistle-stop tour there. We packed a lot in there. So I suppose some of the key things I'm taking away from today's talk in terms of human factors, there's so many different elements to think about. Just culture, safety 1, safety 2, the situational awareness, huddles, team working, governance. And I suppose for our listeners online, if we're trying to think about, if we bring it back to that just culture and how do we actually implement that in our systems or in our healthcare organisations. So say, for example, I'm a physio working as part of the larger team in one of the hospitals, and I'm listening to the webinar and I want to take something away from it and try it. Is there anything even at team level or anything that you would think about or advise our listeners with respect to looking at that?
Yeah, so I suppose it's really about people feeling safe enough to speak up. So maybe as a team you could get together and, like there are, we use kind of, say, cuss words, so trigger words that if I'm concerned, cuss stands for concern, unsafe, or stop, So maybe as a team, co-design your own words, like what would be a trigger word for your team in terms of, listen, I'm feeling uncomfortable and I'm not able to speak up, or look at why you're not able to speak up, look at what are the characteristics of the team, but look as well at your data. I think it's really important to look at patient safety data and ground it in that. And the World Health Organization, you produce some really good resources here around patient safety for the first World Health Organization Day on patient safety. And when you think 5 people die every minute from patient harm, it's an extraordinary figure. And the first topic they chose for their team was speaking up about patient safety. So why can't we speak up more? What's blocking us from being able to speak up? And there's so much in the culture in healthcare. There's so much fear, there's so much bullying, there's so much mistrust. there's so many factors in it, and they can come from, you know, the siloed working and from organizations with very strong hierarchies tend to have lower psychological safety, where staff aren't as involved in, you know, looking at and designing their work and their work systems.
Yeah, and I think that's key, isn't it? It's about that co-design piece from the start with staff. Yeah. So we have one comment that's come in. So Lorraine Murphy is saying, well done, and thank you, Marie, most informative, and can we get a copy of the slides, which is perfect. Yeah, that's no problem, Lorraine. We will do that. The slides and the recording will be available on the QITalktime webpage thereafter. So I don't see any other questions coming in, but certainly there's lots of elements within that in terms of the safety huddles, the team working, situational awareness, that certainly we will target with webinars in the new year. You could give one webinar to each one of those topics, so certainly we'll do that in the new year. And also, I think of interest to our listeners particularly would be one of the next webinars, which is the co-lead intervention toolkit, which certainly for teams, for developing teams, I think it's a great toolkit, which is now available, I think, as of yesterday, I think, online, the actual toolkit. So thanks for everybody for joining in, and thanks so much, Marie, for coming and giving us all her wisdom on human factors, and hopefully she might join us again next year, where we can do a more deep dive into some of the topics we discussed today. And just to finish, so we have 2 more QITalktimes before the end of the year. Tuesday the 26th of November, we have the University Hospital Limerick coming to share their QI journey. So I think this will be really interesting, because I think around the country we have a lot of new roles, for example, QI facilitator roles that are popping up around the country, which I think would be great for people to log in and see how UL have built their QI community in their local hospital. And then on the 10th of December, we have the co-lead, as I spoke about, so Dr. Aoife de Bruin will join us for that. And any other queries, please do pop me an email, roisin.breen@hsc.ie. And without further ado, please, thanks again to Marie for joining us, and hopefully we'll see you next time on Talk Time. Thanks very much.